Welcome to Pre-Training Therapy for the Preemie graduate. The presenters today are myself, Cheri Fraker, and Laura Walbert. This is our ASHA disclosure statement. And we're going to talk about common problems for the Preemie graduate. Prematurity does not end. The term infant is made ready to feed. The baby comes into the world in physiological flexion. They have the nice fat pads in the cheek, the tongue fills the mouth, and this baby can take deep breaths. Digestive tract is working. This baby is an eating machine. Contrast that with the premature infant. This baby does not have fat pads in the cheeks. This baby struggles for air. And the challenge, the aerobic challenge of eating is very difficult for this baby from the point of taking the bottle all the way through digestion. In this first part of the lecture, we're going to talk about some of the problems that you can see working with a pediatric feeding team and what issues can actually derail feeding for the preemie infant. The feeding challenges in NICU, they show themselves in childhood. You have to go back in time when you have a child who's really struggling and take into account everything they've been through just to survive. The preemie is at high risk for aerodigestive disorders. What happens in the belly impacts the nasal breathing. High-grade laryngopharyngeal reflux can cause a whole host of problems, or postnasal drip and drainage can impact the belly and the GI tract. So there's a snowball effect that we'll briefly talk about of feeding problems in the aerodigestive tract. Congested nasal passages lead to air swallowing. The baby must open the corners of the mouth to swallow air while they're trying to feed. Swallowing air can be rocket fuel for reflux, and then the baby is in that vicious cycle of reflux coming up high, irritating the nasal passages, making mucus and drainage. And then the baby must breathe by mouth while feeding, and that increases the risk of aspiration. Is there more to the story, though? Does the child have gastroesophageal reflux, or is there gastroesophageal reflux disease? If there's complicated GERD, gastroesophageal reflux disease, are you seeing symptoms such as poor weight gain, excessive crying or irritability, a lot of arching, discomfort, feeding problems, aversion? Are there respiratory problems and wheezing and stridor? Is the baby actually developing pneumonia? This is the point where you would want to talk to your physicians, pediatric GI, dietitian, determine why is the baby not tolerating the feedings. Reflux can travel high and cause reflux laryngitis and inflammation of the upper airway, and that can lead to a whole host of problems with the swallow. Pharyngeal receptors are not as active. The baby can have more problems with aspiration. You want a nice, pink, normal, healthy looking upper airway. Now, vomiting, constipation can also be leading into milk protein allergy. If you start seeing a rash pop out and the baby starts feeding, gets little red dots around the face, is arching, uncomfortable, aversive, you have to consider when the skin is telling you a story. Vomiting and constipation are also telling you a story because that child's on a liquid diet and it should be easy to pass a stool. Don't wait and talk to your pediatric GI and dietitian. There are other digestive tract disorders we must consider. Is there a history of necrotizing enterocolitis? Is the child absorbing nutrients? Are there hard stools or watery stools? Is there a strong fishy odor to the bowel movements that could be concerning about absorption of nutrients? Is the child having poor weight gain? Are they having chronic diarrhea? Is the baby failure to thrive? Or do you consider that maybe the baby has a motility issue? And again, that's where you start those conversations with the pediatric GI. The babies do need special formulas. Some families need help with that. And talking about growth is very challenging for the parents. Many times they're very fearful of, is my child going to need a G-tube? Have I failed my child? Nutritional rehab is number one. If a tube is needed, it should be accepted. and the family should not feel guilty about this. It's just like having a brace on a leg. Some children do need tube support, and making those decisions early and helping the family feel good about their child's nutrition is always number one. Is the baby aspirating? Is this an oral motor problem, or is there something with the anatomy, or both? You start through the checklist of yourself. Am I on the correct feeding product? Is the flow rate appropriate for this child? Does positioning change help? And if I'm pacing the feeding and allowing breaks for the baby to breathe, does the feeding quality improve? Am I treating the aerodigestive tract to improve the child's ability to form a bolus and to control it? Am I putting saline in the nose and keeping it open if the doctor agrees? Is the child on reflux medication if the physician has wanted one? Have we tried some things, but we're still seeing issues? What do I do next? My oral sensory motor therapy is in place. I'm doing swallowing therapy. Do I thicken? Yes or no? And that's a slippery slope. Thickening is not treatment. Thickening is a modification, and you're still wanting to treat the thin liquid swallow. How do you do that? And we'll talk about that in pre-chaining therapy, but you must work with your dietitian. There's a whole host of concerns about thickened liquids and the premature baby's GI tract. We have to be careful that we don't just jump to thickening and think we fixed something. Swallow studies are always needed. Are there other anatomical problems? Is there a type 1 laryngeal cleft, which is shown on the left? This laryngeal cleft can cause a whole host of swallowing problems. Are there hypertrophic adenoids? When this child has, on the right, has an adenoid that's completely blocking nasal breathing, heavy secretions there, that's postnasal drip and drainage, sleep issues, and problems with the pressures for swallowing. So this is where your ear, nose, and throat, your ENT, is important to look at the upper airway. Also consider the risk of salivary aspiration or aspiration of secretions. This is the least recognized form of aspiration. And children who have a neurological impairment who aspirate their saliva due to severe swallowing incoordination and absent laryngeal sensation, it may be that that's occurring instead of excess saliva production. You need to determine the severity of salivary aspiration, and these are conversations you would have with the ENT. Assess the degree and type of aspiration, a swallow study, a FEES assessment. Rigid bronchoscopy and a bronchial alveolar lavage may be needed. You get lipid-laden macrophages that you test and look to see how many of those lipid-laden macrophages are in the sample. Is the child aspirating gastric content? Are they aspirating secretions? Are they aspirating the feeding? Impedance testing is a GI test that may determine the degree of reflux. So again, in the beginning with the premature infant, you need team care. You don't look for simple answers to complex problems. These children need a team to succeed. Gastric aspiration can devastate the lungs. You're looking for symptoms such as chronic cough or wheezing. Some children do have bronchospasms. They have poor sleep. They may cough or wheeze after feeding, stridor or hoarseness. But do know that the premature baby can also silently aspirate secretions, feedings, gastric content. Therapists can assist with teaching the parents about positioning after tube feedings or oral tastes or limited feedings. There are things we can do to help, but we're doing diagnostic therapy here. We're monitoring the children and seeing how they do week to week. If there are problems with the suck, swallow, breathe sequence, we have to build this. This is the foundation skill of all feeding and will impact feeding throughout life. The baby must learn to coordinate this to feed safely and effectively. So assess their energy expenditure. Are they head bobbing? Are they very fatigued with eating? Nasal flaring, changes in their swallow. And know that if the feeding is going too rapidly, the baby will start to lift the tongue to the palate to stop the flow, and they will actually develop a maladaptive feeding pattern. And this can persist, and it's exaggerated by changes in the anatomy with growth. At 6 months, the tongue starts to descend in the mouth and the larynx drops, and suddenly the challenged preemie now has to deal with more room in the mouth. Many times, unfortunately, we move to a higher flowing feeding product at this time, and this can be the wrong decision. Many times, some preemies will need to stay on the preemie nipple the entire first year of life. Some can go to the one, but slowing it down is always a good idea to build power in the anatomy and to help with bolus formulation and control. Those maladaptive patterns, that leads to a munching pattern, and that can actually go into the future and cause aversion. Is there aversion because of just the feeding, or does the child have a lack of good feeding skills? So the basics in the beginning with the common problems is the inflamed aerodigestive tract, the beginning of picky eating and feeding aversion. If the child is eating like Pac-Man in that up and down munching pattern, that is the child who many times will eat chicken nuggets and macaroni and cheese and crackers and the goldfish crackers and the foods we commonly think of in the picky eater. And actually the beginning of this could be the aerodigestive tract. Laura's going to talk to you now about pre-chaining therapy and what our treatment programs look like in action.
Okay, so we know that there are critical periods for development at different stages. And Colin Rudolph referenced or talked about this article that the infant's nervous system is primed to acquire new motor skills at different periods. But we know with our preemies who have graduated from the NICU, those might be altered. They may have those critical periods missed because of a medical procedure, something that they can't do because of their developmental status. And so we're going to talk a little bit about how we fill in those holes for babies and how we alter what we give so that the premature infant can be successful acquiring the necessary oral motor skills in a safe way that makes sense, that one skill builds on the next and are developed in an order. What we don't want is a baby who has different skills, but they don't have good foundation skills, because that's not going to take them through all the necessary critical times to be able to accept complex foods, be able to accept liquids in a more complex way from a cup. So we have to do this in a smart progression. So if you think about the baby in the NICU, and this is Jordan, he was a micro preemie, and here he is at 1 year of age. And when you look at him, he looks like a newborn baby, a small, tiny baby, and he's 1. We know he does not have the head control to sit and take spoon feeding. We know he does not have the musculature and the oral control to be transitioned to a cup at his size. So we need to make accommodations for him so that we're giving him some exposure to the necessary skills in a modified way. So what are pre-chaining programs? Pre-chaining programs can help aversion be prevented. We feel like if we do things in a smart order, if we do them in a modified way, that kids don't have to be aversive later on in life, that their feedings can be pleasant and we can develop the skills to grow those feeding skills. We do pre-chaining programs for children considered to be at high risk for developing feeding disorders. So we all know those diagnoses where we think this child is not going to be on track, and we can start planning ahead for them so that they can be successful at whatever level they are at. We work with pre-chaining programs for children who aspirate. Even a child who aspirates gets feeding therapy, and we do some oral feedings with the doctor's permission in very small amounts. We use pre-chaining programs to normalize perioral and intraoral sensation and to stimulate the development of the necessary oral reflexes so they can later be successful with feeding. So pre-chaining programs literally are for anybody who we think might not stay on course. So a pre-chaining program for the first year of life. So we're thinking about in the NICU, but then also at discharge. What are they going to need? What obstacles do we think are going to happen in that first year as they're acquiring feeding skills? And this is a very proactive approach to infants and children at risk for developing a feeding disorder. So when you think of in pre-chaining, you should think of preemie care, precautionary care, preventative care, and being prepared for each stage. So the therapist who approaches a preemie graduate or a preemie in the NICU should be thinking about all of these things and make smart decisions about how they are going to approach their therapy sessions for this infant. Pre-chaining programs are intended for to avoid problems or to fix them. So when we're approaching a child who we're just getting started in therapy, either in the NICU or as an outpatient, or in their homes with the preemie graduate, we are going to think about avoiding problems. So we're thinking about being proactive in how can we provide the oral stimulation, the textures, the necessary tools, the cups, the spoons, the bottles, everything in a very systematic way that is not dependent upon volume. So if you think about a child who is going to be exposed, needs to be exposed to spoon feeding, we are going to get the appropriate spoon. Maybe that's a textured spoon, maybe it's a chewy spoon, maybe it's a hard plastic spoon, whatever they need, and we're going to introduce the skill of spoon feeding. Maybe we're only going to put a dot of flavor. Maybe we're just going to dip that spoon in something, shake most of the volume off, so that they're just getting basically flavored secretions at this level. So while we're introducing a spoon, they don't have to worry so much about swallowing a bolus. They're just going to swallow their flavored secretions at this level. So we're going to do those introductory skill levels, and then we're going to give time to master those. We're not going to jump ahead. We're not going to think about volume. We're not going to give parents a target for how much intake they need to be achieving. We're just going to stay at the level of introduction. Also, this is appropriate for infants who are stuck at a transitional level, or for the older non-oral feeder. So this might look like the child that's having difficulty, that's not able to transition from bottle to breast or breast to bottle. Maybe they're the kiddo that's having difficulty with transitioning to more textured and advanced skill type foods. And we're going to stay the course and work on the introduction, work on the necessary skills without any undercurrent of pushing them past where they are from a skill development standpoint. Pre-training programs are also intended to address the skills necessary for children who are tube dependent. So there are some children who are going to require feeding tubes either as their primary nutritional source or as a supplement to some oral nutritional source. And we still are going to work with those older children who are tube dependent in the same way. We're going to think about where they started, what skills they don't have, and help them develop those necessary skills to make that same progression. So it doesn't matter if this is a term baby coming home from the NICU, or if this is a 7-year-old who has never eaten and is tube dependent at this point. We're still going to use the pre-chaining principles to achieve the skill development, oral sensory, oral motor acquisition, so that they can be successful at whatever level. So let's talk about the basics. So we're going to determine and treat the cause of whatever kind of feeding aversion or feeding disorder that presents to us. So Cheri talked about all of the upper airway and some of the GI things that can interfere with feeding. Anytime we are assessing a baby, we need to be thinking about those basic things. Can the child breathe? And what is the end result of feeding? That is absolutely critical. We also want to look at their sensory system. Can they tolerate what we're doing? And do we need to back up and maybe have our occupational therapist address some things before we can address feeding at a higher level? So we don't want to push through. And I think a lot of times speech pathologists get kind of clued into, I am working on feeding, so the child must eat. And we definitely do not agree with that. We want our sessions to be smart and achieve the necessary oral sensory skills too. So we definitely have sessions where children do not eat, but we're laying that basic principles and basic foundations of tolerance. So I always tell parents we're building a bridge, and if you have one side of the river and we're putting on each piece of that bridge, and that might start with just being able to tolerate touch and giving parents the instruction of how to progressively work that very aversive baby toward their face so that they can tolerate that type of input. That's absolutely necessary. If they cannot tolerate touch, we have no business bringing any kind of food to their mouth at that point in time. When you're thinking about the preemie, we always need to think about breathing, because the respiratory system has to be in place that supports oral feeding. The body will always choose breathing over eating. So our physical therapists are involved with our patients, and that's that team care, team approach, using our resources of OT and PT to help us have a child that's ready for oral feedings. We're going to nourish the child while building the feeding skills. So our dietitian is involved with these patients, making sure that they are nutritionally sound. Above all things, nutrition comes first. Our dietitian also helps manage tube feedings and help avoid tube feeding dependence. So when we have preemie graduates that we get right out of the NICU, I feel like we do this very well, that they're managed well, so that we're building some skill talking with the dietitian. She might adjust the tube feeds so that they can take a little bit more, and they're not always 100% tube fed through those conversations. So I feel like when we get those babies early, we're able to get, maybe if medically appropriate, move them to more of an oral feeding schedule. Some other children, they absolutely need that tube feed, and our dietitian is there to manage that tube feeding for success for them, and that process might take much longer to get to some oral feedings. We want to safely increase oral intake as it's tolerated, and the child is our guide. They show us. So at all stages of therapy, there should be a conversation between therapist and child. Child responds, and therapist needs to tailor their next thing based on how the child responded to the initial input. It is not that we have any kind of an outline or a map or any kind of a plan, because the child who's sitting in front of us is going to tell us how far we can take them, how far, what can they tolerate, how far can we go, and that's based on their responses and not on our agendas. Okay, so pre-chaining therapy programs, what to do in therapy. With that infant, we're going to start with pacifier programs to try to help build the non-nutritive skill pattern. So we want to work on non-nutritive sucking. There's a lot that comes into play with being able to suck on a pacifier and breathe through the nose. We use the Dr. Brown pacifier to help achieve these necessary skills at this level. We don't want to skip this. So a child who can't tolerate non-nutritive sucking, yet maybe we're just going to work on touch and pacifier introduction. We want to be able to stimulate that non-nutritive sucking pattern if at all possible. In pre-chaining therapy programs, when we're providing taste, sometimes it is just a single drop of breast milk or formula, basically just to flavor the saliva for that non-oral child. And we only increase the volume when it's safe to do so. So we might have parents just dip a pacifier and offer it, and we're still working on tongue grooving, we're still working on lip seal, we're still working on the strength of the suck through traction, getting that child ready. And when we talk to our physicians and our neonatologists about what we're working on, these are pre-feeding skills that must be developed so that the child is ready from an oral motor and an oral sensory standpoint. So pre-chaining is about functional oral sensory motor therapy planning. And so we're planning ahead with that pre-bottle exposure. A NICU graduate who is tube fed, we might use that graduated feeder where it starts out with just a no flow and then a little bit of flow and work our way up to a slow flow nipple or an ultra preemie nipple, whatever level they can be successful with, but we're planning ahead. How are we gonna get there? So we wanna do that very systematically, very intentionally. I talked a little bit about pre-spoon and what we do. We can rest that spoon on the lower lip, just work on the opening and the acceptance. We want babies to show us a positive tilt coming forward, opening the mouth, showing that they're registering that a spoon or some sort of input is coming to them, and then they respond in a positive manner so that we know that they're accepting. A pre-cup therapy program might look like just taking the top off of a sippy cup and putting it in with their oral motor toys or just their teething toys. They're going to start to get the idea of how to configure the mouth around the spout of that cup. Maybe there's just nothing coming through that cup and they're just learning the oral skills for mouthing it. Some soft spout cups we're able to just put a very light film of flavor on there, and they start to chew on that. Maybe they're just start to suck on the cup just with flavor and nothing that they have to yet coordinate that suck, swallow, breathe sequence. The pre-chewing therapy programs can be achieved with some of our oral motor tools. There's lots of different chew tubes and bite arcs and duo spoons and things that we use to teach that pre-chewing program. So they're chewing on a chewy utensil, not yet chewing on food. So all of these things are exposure without any risk of having a bad response, any risk of any aspiration, anything negative happening. So we're trying to minimize any kind of further aversion. So we're going to mimic the experience that the child is missing at meals. So when they can't do it, we need to think, how can we modify it? What can we do to mimic it and offer those types of supports at that time? So in therapy, we might be working with that single bolus swallow, and we're going to work all the way up to successive swallows of liquid. We feel that it is very important to look at positioning. And for many of our infants, we are using the side tilt positioning. And I want to highlight side tilt and not side lying. So we're borrowing from breastfeeding. When the one cheek is down toward the floor and the baby is in an upright position, that helps with bolus control. It helps with posterior movement of the bolus. And then we work strongly on that external pacing of the feedings, where we're allowing that baby a certain number of sucks, and then we're imposing some pauses so that they can have a good foundation of the suck, swallow, breathe sequence. And during that first year of life, we always say, go slow, use that ultra preemie nipple, use the preemie nipple to build strength and to protect the airway. Gone are the days of thinking that we'll take the work out of the oral stage and just get those feedings down. We want them to take smaller volumes, but build skills. We want them to think about what skill is being developed rather than how much they took in. So think beyond volume. Think about what we hope to achieve. During the first year of life, pre-teens therapy programs consist of exposing children to the sensory experiences of food. We have patients who come in for feeding therapy and the parents will say, I feel so guilty eating in front of my tube-fed child. I feel like it's not fair to them. So we eat separate from the child. When the child goes to bed, then we bring out, our meal. And that really disrupts family life. So in the very beginning of therapy, we always talk about sensory exposure to the aromas of food and providing that sensory experience that a child can tolerate. So we want that child in the kitchen while mom is cooking. We want them getting their tube feeding while they're sitting at the table and the rest of the family is eating. We want to offer, at whatever level that they can tolerate from a tactile standpoint. Maybe they get a little sauce of something that the family is eating on the tray and they are experiencing that. So we're working on all of the sensations at this point. So smell and touch, and if they can be exposed to a little bit of flavor, we want to provide that. So as the child can tolerate and as they grow, we're going to give those tastes of baby food, or maybe if we're past that baby food stage and the child is doing okay with those more diluted flavors, maybe we're going to use real table foods and we're going to use a light film on those teethers and on those chewy utensils and on those pacifiers. So just think about what is appropriate from a developmental standpoint. Think about what's appropriate from an age standpoint too. Many times at that 10, 11 months, we're moving on to those high flavor foods and we're not sticking with baby foods. Our goal is that we can get them to flavors of real food. So we start that exposure. And when we do that, we want to make sure that we're offering from all flavor families. We as therapists, I think, get stuck sometimes about what we have with us, what we can obtain in our therapy department. So we don't want to just offer applesauce. We don't want to just offer pudding because it's available to us. We want to make sure that we're offering tastes from all flavor families. So we've used things like chicken broth and beef broth and, the saucy part of baked beans and dill pickles, anything that the family is eating, we want to start exposing them to. So we spend a lot of time talking with our families about what do you eat as a family? What do your family meals look like? Kind of run through a menu for us about what you eat so that we start to get some idea of what we're working towards. And then only are we increasing the volume of those therapeutic tastes based on improvements in tolerance, skill level, and swallowing skills. So oral motor feeding therapy programs emphasize that development at all levels, whatever they can do and at whatever volume they can tolerate. So again, do not think about volume at this stage. This is not where we are. And then also, always, if you are stuck someplace, if something is going on and you are not able to make progress, we always need to go back and think about where we might have a hole in our development. A baby cannot bottle feed if their nose is occluded and they cannot breathe through their nose well. They cannot tolerate their secretions. We need to address that. If they're vomiting, we absolutely need to address that because all of those medical things can derail feeding programs from being successful. So if you're not making progress in a reasonable amount of time, always be going back and thinking about those things. So if we're thinking about just looking at what this might look like during the first year of life for a therapist who is approaching a baby, maybe as an outpatient right out of the NICU, and we know that they might be a patient who has multiple physical challenges. They're not going to reach those feeding developmental milestones according to their progression. We're just going to start with oral motor. That's our level 1. Oral care, tolerance for touch, all of those pleasant oral experiences that the baby may have missed because of all the medical things that they had in the NICU. The nasogastric tubes, the endotracheal tubes, that changes the oral sensory tolerance. So we're going to work there. Then we're going to work on secretion management. We're going to get out those pacifiers. We're going to work on that non-nutritive sucking. We're going to see if they can swallow their secretions. If they're successful there, then we're going to go on to taste level 1, and we're going to offer those tiny little drops of formula or breast milk at whatever level they can tolerate in terms of volume. Oral motor level 2, we're going to start maybe introducing spoon. We're going to start introducing all those chewy utensils I talked about. And then at taste level 2, we're going to start introducing that pureed table food or maybe some baby food here in all flavor families. And we're going to start laying all the foundations all along the way for a more challenging oral motor and oral sensory tolerance. So always remember that this is diagnostic. And we talk about diagnostic therapy. It's because we're doing therapy programs, but we're always diagnosing where we are, what's new, what's changed, what needs constant reassessment, and that's the swallow. Always, always reassess the swallow using cervical auscultation at each session. We want to know when we make a change, how do they respond? If we're going to do some thinner purees and then we're going to get into some thicker purees, we want to know how is their swallow challenged. And cervical auscultation is a great way to be able to subjectively say what's going on. If it's okay to feed, we need to help families determine how much and what nipple flow rate is the safest for the entire feeding. So if we have an oral eater and they do really well, maybe on a level 1 nipple at the beginning of the feeding, but then their feeding falls apart mid-feeding, and they're not safe with the level 1 nipple, then we are not going to recommend that. We're going to go to a preemie or an ultra preemie nipple so that they are safe throughout the entire feeding. So feedings can be any amount, and it's dependent upon the child. So what tube or oral feeding schedule should the baby be on? Sometimes we don't know that until we get into working with a baby. Sometimes we can do a tube feeding at every other feeding and oral feedings in between if the child can tolerate that. Maybe it's a combination of both. Maybe they get a little oral exposure and then a little bit of a tube feed after. We're reassessing the baby's growth, working with our dietitians and physicians to make sure that what we're doing at each level, baby continues to thrive. We're always assessing that the baby is comfortable and that what they're getting, not only during the consumption of it, but afterwards, and the end result of that feeding is comfort and enjoyment is very important. And then some babies need concentrated feeding so that they can take less volume. So we need to think about all of those things as we're progressing through these therapy programs. So we have to treat breathing. Always think back about that. Whatever you need to improve breathing patterns is going to improve your oral sensory motor skills. That includes your physical therapist working on Mary Mastery courses, techniques to help the baby breathe better. It's maybe just tummy time helps baby have better respiratory skills. That's going to improve your swallowing skills, so don't overlook that. And in your therapy toolbox, we're going to have those Dr. Brown pacifiers, the ultra preemie nipples, the preemie nipples, and the level 1 nipples, and always opt for the slower feeding products. This is a little bit, this is Lucy, a little bit of her PT session, that supervised prone positioning. That is what was critical for Lucy to build that respiratory system to support feedings. This little lady is a NICU graduate, and she is missing power in that oral motor mechanism. And you can see that she has that open mouth position, and maybe that's because she's having some difficulty with her nasal breathing, but she does not have power in her anatomy. So we're going to address her nasal breathing. We're going to address improving lip closure. We're going to do a lot of non-oral activities to help her with her feeding skills so that we can work on improving those oral sensory tolerance, the oral motor, and the breathing skills all at the same time. All right, your therapy tools. We want products that are going to improve strength of the lip seal, improve sucking strength. So pacifier programs are a great way to do that. We are going to use what we know works lip seal, traction that pacifier, make that baby work a little bit harder to improve their sucking mechanism. Work on their secretion management through your pacifier programs, and work on all those necessary skills of tongue grooving, so that when we do transition to oral feedings, that baby has a way to control liquids. We're going to go with the flow, and remember, less is more, and flow rate is absolutely vital for the infant and the child in maintaining adequate breathing while they're feeding. We want to get away from any high flow products and go to slow products. And remember that infants may take more volume over a 24-hour time period on a slower flowing product than they do on a faster flowing product, and they're going to be safer from a swallowing standpoint. So if you see that it's too fast, how can you intervene? You can limit the bolus size and help control the flow rate based on the nipple that you're providing. You can reduce that gulping and support a better, more stable respiratory pattern working with that suck, swallow, breathe sequence. If that child is gulping down those feedings, remember the end result is going to be GI discomfort. So they're going to feel distended, and they may have taken a smaller feeding and getting a false sense of fullness because they're so full of air. So they are going to be miserable. So we want to work with our Dr. Brown products, which we know takes air out of the feeding, and then help them with their suck, swallow, breathe sequence and a limited bolus size. All three of these are going to be critical for a successful feeding. Try those preemie nipples and ultra preemie nipples. If you see liquid coming out of the mouth, impose those breaks with those suck, swallow, breathe sequence patterns to help them be able to tolerate what they have. Limiting that bolus size and adequate ventilation is critical. So this will help your baby learn those feeding skills. Remember the upright side tilt position. That helps with breathing. It's less effortful breathing, results in improved swallowing for babies with respiratory issues. So that side tilt position can't be emphasized enough. The side tilt position and the effects of gravity and the fluid flow rate are reduced versus when they're in an upright position. So try those in your therapy sessions. So here's a picture of a baby in a side tilt position with a Dr. Brown ultra preemie nipple, and we're just working on tolerance of single bolus swallows with this infant at this time. Oral sensory motor feeding therapy programs for that child that might be 6 months and up. Think about reducing flow rate at this stage too. So think about small diameter straws. Think about those little juice box size straws. Maybe you start with just a little pipette of a liquid in there so they learn those oral skills. Think about that Think Baby straw cup. So that has a nice small diameter and also has a little flange at the end, which slows down liquids versus an open straw cup. Think about using sensory loaded liquids, which we know from Logoman helps with the timing of the swallow. Think high flavor. A lot of our preemies or a lot of our babies who are mouth breathers, they really thrive on high flavor foods. Remember all your chewy utensils to help master and mature those oral motor skills and build confidence before you move on to food. And let it be fun. Always let it be fun and let it be with enjoyment. We do not want any infant or child thinking that they're going to the dentist and having oral, kind of an oral exam. We want to make sure that this is pleasurable and self-directed, give that baby that chew tube. Let them do it. Let them bite on the Duo spoon. And it'll be interesting. They can do their own therapy. It's interesting to watch where they put it. It tells you a lot about their oral motor, oral sensory tolerance. And this is Alex. He's a Preemie graduate, and here he is with a bite arc and on the left-hand side and a Duo spoon on the right-hand side, and he is totally doing his own therapy, and he is directing it where he feels safe. And we can help him achieve those skills, but let him do it a little bit on their own and see what they can do. So here he is moving on to spoon feeding, and it started with all those chewy utensils. Just remember, anything can be a spoon. It doesn't have to be a spoon. It can be a chew toy. It can be a Little People from Big Sister's Playhouse. It can be absolutely anything. Some kids do not like the idea of a spoon coming toward them, so get rid of them and just use some sort of a toy or an object with a little bit of flavor. So pre-chaining therapy programs are always about advancing the program as the child is tolerant. We want to keep everything absolutely positive, not to push them at all, but to read their cues and to teach families to read cues. We narrate the child. We say, I saw when your baby did this, I think they're telling us this, so that they start to get the idea of what those cues mean. It is about quality over intake, always, and it is always, always about parents being educated about the plan and where we are in the program. For the older child who might be a non-oral feeder, we're doing the same exact things. We're just building that treatment plan in a safe progression, just like we would for an infant. So these are not just infant-specific programs. So here's this little guy after treatment eating an orange. He had all the same treatment. He was a non-oral feeder at the beginning of his pre-chaining program, and now he is interacting with foods at school. This is his Halloween party, and he's participating with the other children, and he's safe, and he is enjoying his oral experiences. Here he is eating candy corn and being able to chew that. That all came from work with chew tubes and the Duo spoon, that he was able to get to this level to be successful. Just let eating happen. Enjoy it and not endure it, and make sure that your goals reflect enjoyment.
Okay, we're going to talk about transitioning home with a case study. This is Gentry's story. He's that very complex Preemie graduate, and sometimes you look at all the things to do and you have no idea what to do next, where to go. It feels very much like looking at this sign. You start writing everything down and start putting your treatment in that good progression. So who is Gentry and what were his feeding challenges? Well, we know that everything started at birth because he was 30 weeks. C-section delivery. He was just a whopping 1 pound, 11 ounce. He had severe intrauterine growth retardation. He had hypothyroidism and constipation. What's important to know is that Gentry was in the NICU for 72 days due to inability to feed orally. This should be your huge red flag that Gentry has dysphagia and he needs team care. So he had some procedures when he was in the NICU, but was his testing complete? He had an upper GI at 9 months. That was done just to look and see, why was he vomiting so much? Did he have some kind of rotation or narrowing in the tract? He had an echo 2 times. He had an MRI. He had some x-rays, and then NICU decided to place a G-tube, but no one consulted pediatric GI. And it's important to know that he never had a swallow study. So Gentry did some feedings in a row, and sometimes kids 24 hours, 36 hours of good feeding, and they get to go home. Well, when he got home, he was still struggling because nothing was addressed about what to feed him on when he went home. Gentry was referred to our team after working with other providers because mom wanted a second opinion. He was seen in our clinic from November to April, And a team was formed because we knew immediately that he needed it. It started with myself and speech. I got PT involved to work on breathing. I needed a dietitian and GI to address the problems with tolerance of the formula, the pore growth, and that he was vomiting a great deal. ENT was involved later. We started with GI just to look at the aerodigestive tract. And it's important to know that he reached his treatment goals in 6 months. If you're not making progress in 3 months, go back to the drawing board and look at all the things we've talked about today. There's a hole in your program somewhere, and we need to fix it. So basically, Mom came in and said, Gentry's not made any progress. And I said, show me what they're doing. He was being fed using a level 3 fast flow Avent bottle. The flow of this bottle was tremendously fast, and he was in extreme sideline. He could not form a bolus. He was trying to get this feeding down, and yet he was still 100% tube fed. So there was no desire to eat. And as soon as he was laid back, he vomited. Gentry accepted very little liquid. He had severe spillage of everything out of his mouth because basically he was lying down on his side, and he presented with signs and symptoms of aspiration. More than anything, I saw the extreme stress and panic that he had, and an anxiety cycle that starts when you're trying to feed and breathing comes first. That stress can carry over and be a long-term issue with just your overall health, but also can be a real turning point into strong oral aversion. The stress was very high. He had that symptom complex of vomiting, reflux, constipation, wasn't referred for anyone. He had emesis up behind the nasal passages, so he was chronically congested. The nose hates acid. He had dark circles under his eyes. He was snoring. He was not sleeping. Mom reported that she could never lie him flat even to change his diaper because he started choking on gastric content. And also, I asked Mom how she was doing because she had been on such a stress cycle for so long. And she cried and said, I've not been able to sleep for the past 11 months due to my fear of Gentry choking. So there was anxiety for the entire family. He was also getting EI services at home and coming back and forth, and the EI team decided he needed to try baby food. They thought that that could be easier for him. Now, Gentry did not enjoy baby food, and he had very poor skills to control stage 1 baby food. Why is that? Because he couldn't control liquid yet. He had been fed with something so fast, he had maladaptive patterns, he had no strength in his cheeks, he had poor lip seal. So think about this liquid food running back over the back of his tongue into his airway. And I said, absolutely not, that is not the right plan. They thought because he could breathe around it, it was smaller bolus, but no, we did chewy utensils during that time and let him work on some self-directed oral motor. But we could not add something else when he wasn't skilled at the very basic levels. Basically, the way treatment had been handled, he wasn't able to succeed. And there were real warning signs of a big feeding storm. So I got GI involved. I talked to the dietitian. What can we do with the tube feeding? I got PT involved big time working on respiratory efficiency. They ordered an abdominal binder to work on deeper breathing and that aerodigestive health. Then we sat down and we said, where's this plan going? Where do we want him to be in 6 months, in 9 months? What are we going to do about the anxiety? What are we going to do about the sleep? What else are we missing? PT was key. We've got to get air. You can't be aerobic and feed until you can breathe. So PT's program, we saw a lot of progress in the depth of his breathing. The PT actually just put her hands on his rib cage and gave him support, and he took this deep breath and deep exhalation, and his mom said that's the first time I've ever heard him breathe like that. So we knew that was key. We got those tube feeds under control so he wasn't vomiting so much, and we determined there'd been so much reflux, adenoiditis, he had runny nose. We said we have to get this treated, we have to send him to ENT, so we made that consult. Healthy breathing, healthy aerodigestive tract leads to the nourished child who wants to learn to eat. So we had to set him up for success. I changed the bottle to the Dr. Brown level 1. We started building some power. I didn't care how much he took. I just wanted him to have the experience of moving that liquid back. I got him out of that sideline position in a more upright position. He liked the chewy utensils very much. We started putting just a dusting of powder, like powdered sugar on them. We rubbed them on some high flavor, like on a Dorito. We got him used to just powder residue on his tongue. Then we were able to dip him in more things like pureed table foods. He was a seasoning craver, big time. He loved it. With some practice on these chewy utensils, he came in and I said, I want to see what he does with a half a graham cracker. And the first time we gave it, he ate it. And his mom just about fell over. He also ate 1/4 of an apple cereal bar on that day. And we knew we were making progress. But we had that awful issue with vomiting. Now, the G-tube was a big discussion back and forth between the NICU team that had taken care of him in their follow-up clinics, the EI team, our dietitian. There were a lot of people, too many people involved. Mom told us she had a huge supply of frozen breast milk. She was told not to use it and to offer Infocare formula instead, but he was not tolerating it. He had severe vomiting, constipation, and laryngopharyngeal reflux. The dietitian, they were working on this, and in the meantime, our dietitian said, let's add calories to the taste that he likes. The NICU team wanted to go to Pediasure, and our dietitian thought that would be the end of oral feeding. His weight gain at this point was rapid and excellent, and he was eating new foods well. Pediasure at this time could have blunted out his desire to eat. So we opted to go with breast milk in the tube again. He went from being 100% tube fed to being able to have a cutback in tube feeds. And when that happened and the vomiting stopped, he started eating portions of food such as pork chop, Italian beef, chicken nuggets, eggs, prime rib, shredded chicken, sausage, roasted pork, garlic bread, apples, cottage cheese, green beans, black beans, and salsa. His diet had changed dramatically. Now, he wasn't eating tremendous portions of these at first, but as soon as he figured out and mastered it, the volume went way up, and the dietitian just really pulled back the tube feeds. We kept looking at the liquids because that was our biggest obstacle. I monitored that each session. I saw no signs of spillage and gulpy swallows or aspiration with the change to the Dr. Brown. He started drinking more, and then I wanted to challenge him to drink from a variety of products and build some skills. We did a swallow study, and it showed premature spillage, which we would expect, that he had had some more nasal congestion. The ENT started him on Nasonex for a month. His nasal breathing improved, and he started drinking over 5 ounces of whole milk. He not only could drink from his bottle, now he could drink from a bottle, sip cup, straw cup, and open cup. So checking the progress, are we there yet? Is there more progress to be made? Yes, he's eating, but he's still on those tube feeds. And Mom was really attached to those tube feeds. She was very afraid because of his small size. He was tasting, he was eating challenging foods. What did we need to do? Did we need to push the tube feeds and make him grow? Or did we need to cut back and let him eat? He had intrauterine growth retardation. He was going to be a small kid. His parents were small. He was gaining weight. If we pushed more on him, he would start vomiting and stop eating. And we said, let's go big or go home. So we did the Graz program. It's a tube weaning program, and it's in Austria. If you want to learn more about that program, notube.com has detailed information about how to do that. But we did a dramatic cutback in his tube feeds. His weight was monitored very carefully. He could not lose more than 10% of his body weight. Food was made available to him constantly, food and liquid, during the weaning time. So if he felt hunger or thirst, he could immediately take care of himself. Mom was afraid, but once she read through some of the programs at the Graz program, she felt confident. He was offered those food and liquids throughout the day and rapidly progressed to full oral feeding. tube feeds were cut back more and more, and we decided that we needed to go 6 months with no need for tube feedings. We had it in case he was sick. Therapy was discontinued. We monitored him weekly via email, and he had his physician visits, and his tube was removed after 6 months because he no longer needed it. So that's a pre-chaining program in action, and as you can see, it involves a lot of people. If you have more questions about our approach, you can visit our blog spot with food chaining. We have a food chaining fan page. We have a Pinterest food chaining board that has over 800 pins with information and products, and we have our food chaining book. Thank you very much for your time and attention.